get started. I once heard that all good presentations start with a good quote. So I'll put in a quote. There's a quote. All right, but let's get to the main talk. Okay, so we're going to start off with a bit of statistics. I just thought to add this in simply because just to find out the reason that we use maternal deaths as a statistic. It's an important statistic because it reflects the inequalities in access to quality health services, and it also highlights the gap between the rich and the poor. Of note, I wondered to myself why they correlate the maternal death rate to the live birth rate. And when I looked it up, I just found out it's because you can't really keep a record of all pregnancies. So you can't actually get a true reflection of maternal mortality because we don't report all pregnancies. So therefore, we use another denominator, and that's our live birth rate. And that too also shows the access to healthcare and how the health system is functioning. The contributors or the main contributors to maternal deaths are your severe hemorrhage, infection, high blood pressure during pregnancy, or like your preeclampsia and eclampsia, your complications during childbirth, as well as unsafe abortions. The definition for maternal death is the death of a woman during pregnancy or within 42 days after abortion, irrespective of the duration and place of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or unintentional causes. We do, however, still report accidental or unintentional deaths in maternal patients. So in South Africa, it's still mandatory to report all maternal deaths regardless of the cause of them. So factors that make the maternal arrest patient a bit different from our other arrest patients. It's obviously 2 patients instead of 1. We have the fetus involved. There's the gravid abdomen that we need to take care of as it affects our resuscitation. There are metabolic differences with the pregnant patient, which we'll discuss. There's also the causes for the arrest differ in pregnant patients. You might require a scalpel, which we'll talk about. You must anticipate a difficult airway in a pregnant patient, especially as they get further along in their pregnancy. And it's quite an emotionally charged situation. The patients are often young and it's a big event. And then obviously the fetus is involved as well. You'll be glad to know there are some things that stay the same, which is good. So our basic ACLS and BLS stay the same. There's slight changes, which we'll get to, but the main things stay the main things. We still need a good depth of 5 to 6 centimeters and a heart rate or a compression rate of 100 to 120. Your technique still needs to be on point. So as in the picture, your shoulders need to be over your elbows, which need to be over your wrists, so that you're pivoting at your hips and not at your arms. Your elbows shouldn't be bending. And then, you should be compressing at the lower half of the sternum. And as I said, your elbows should be locked. Your compression rate to breath ratio, we're still doing a 30 to 2. So with 30 compressions with 2 breaths. And then at 2-minute intervals, we're going to be doing your pulse checks, your defib checks, giving adrenaline or shocking, depending on the rhythm that's found. So this, and then obviously looking for your H's and T's. There are a few extra H's and T's, which I'll show you in the next few slides. This is your basic ACLS arrest rhythm, which we all, I'm sure, are familiar with. So depending on the rhythm that you find, if it's a ventricular tachycardia, you're going to shock immediately, or a pulseless VTAC. A ventricular fibrillation or a pulseless VTAC. You're going to shock immediately and then go into your 2 minutes of CPR. After 2 minutes, you're going to check the rhythm again. If it's still shockable, then you're going to start with your adrenaline, alternating between adrenaline and amiodarone every 2 minutes if it remains shockable. If it's an unshockable rhythm or asystole or PEA, you're going to immediately give your adrenaline while you're starting your 2 minutes of CPR, and then continue on that 2-minute cycle of checking your rhythm and alternating between the 2 sides depending on the rhythm that you find. And then, I'm sure we're all familiar with this slide. And then the H's and T's, as usual, we'll go through those as well a bit later. This is the specific cardiac arrest in pregnancy algorithm that AHA has produced. I'm going to zoom in on each one and we're going to go through it in detail so we can get a good idea of what it looks like. This is your basic BLS and ACLS program. as we've discussed, it's the same thing. And then you need to assemble a maternal cardiac arrest team. So ideally, you want an obstetrician, you want ED staff, you want pediatric staff, basically as many hands as you can get, because it's quite a big event and it takes a lot of hands, especially in these resources. So if you can get all the people involved that need to be involved, they should be there at the resource. And then you need to consider the etiology. We will chat about that in a moment. And then there's two factors that differ from your other standard algorithm. You have your maternal interventions and your obstetric interventions. So with maternal interventions, the airway management is of great importance in pregnant patients. They recommend that you do try and intubate the patient rather than bag the patient, since the airway is quite difficult to bag. We'll go into more detail in that as well. Together with 100% oxygen, but also avoiding excess ventilation because they already have a splintered diaphragm from the pregnant or gravid abdomen. So you want to try and avoid splinting that more. Also advise putting an IV line above the diaphragm. This is because your gravid abdomen is going to be compressing on your IVC, and if you put an IV line below the diaphragm, then whatever medication you're giving might not be getting to the heart quick enough. So they do recommend a line above the diaphragm. And then if the patient had been receiving magnesium, they recommend to stop the magnesium and to give calcium chloride. This is because magnesium can cause toxicity and arrest, and can be one of the causes of the arrest. So therefore, you want to reverse it during the resuscitation. And then for the obstetric interventions, you want to provide lateral uterine displacement. This is to relieve the pressure on your IVC so that your preload can be increased, and that when you are compressing and allowing for recoil, that there's blood that at least gets back into the heart while you're doing your recoil. They also recommend to detach fetal monitors for two reasons. They say that your priority is to resuscitate the mother. By resuscitating the mother, you will inevitably resuscitate the child. And also they say that there's a theoretical risk of arcing if you need to defibrillate the mom. So they recommend just removing the fetal monitors completely. And then you might also need to prepare for perimortem Caesar, which we would call a resuscitative hysterectomy. That's the better term for this, because the perimortem Caesar just sounds like doom and gloom. And then you continue with your normal ACLS and BLS while this is all going on, and then you can perform your resuscitative hysterectomy. That needs to be done, or needs to basically be started by 4 minutes and be done by 5 minutes. That's not a hard and fast rule. That's more a recommendation, simply because the data shows that past that, the survival rates decrease. However, in reality, I don't think we ever really get to this decision that quickly. It does highlight the fact that we should be trying to get to that decision quickly, and try to start the procedure as quick as possible. But again, if you get to 7 or 8 minutes, don't think, okay, well, the time has passed, we can't do it now. So, yeah. And then just on those slides on the side, so the team planning is very important. As we mentioned, we need obstetrics, neonatal, emergency, anesthesiology, ICU, and basically all the services that we need for that resus. Then just picture all of this happening with CPR continuing. It's going to be, it's not the ideal situation, but we still need to focus on high quality CPR during the whole procedure. It shouldn't just be a focus on the gravid abdomen. And then also that aortic cable compression should be relieved during the resuscitation. The goal of your perimortem Caesar is to improve maternal and fetal outcomes, but by improving maternal outcomes, you also are improving fetal outcomes. Fetal outcomes we'll discuss a bit later as well. There's not really much we can do in relation to that during the resus, but the only thing that we can do is the earlier you perform the procedure, the better for the fetus. And then, as we mentioned, ideally it needs to be performed within 5 minutes, but it depends on the skill of the provider. And then with regards to airway, as I mentioned, they recommend that intubating the patient with an endotracheal tube is the best for resuscitation during pregnant patients, because of their challenging airways and the challenging with bag masking these patients. So ideally, if you can, try to get in an ET tube as quick as possible in order to be able to ventilate them better. And then once the ET tube is in place, we're only going to give one breath every 6 seconds. So we're not going to be doing the 30 to 2 compressions anymore. This is standard, but we'll continue with one breath every 6 seconds. And then with regards to the causes of cardiac arrest in pregnant patients, you will still look at your H's and T's, but this list is just a sort of summary of more pregnancy-related complications that could have led to the arrest of the patient. So they put it in a nice mnemonic, A to H. So your anesthetic complications, think of drugs that may have been used, your high spinals or anything like that. Any bleeding, your APHs, PPHs, all of those, together with your cardiovascular complications, your drugs that might have been given. So your Magsolv, think about all of any other medication that may have been given on admission. And then your embolic causes, such as your amniotic fluid emboli or even PEs as well. Any sign of fever that could be maybe a septic abortion or puerperal sepsis or any other cause that may cause sepsis as a cause of death. And then your general non-obstetric causes, so your H's and T's that are in your normal BLS algorithm. And then your hypertensive causes like your preeclampsia and eclampsia. So it's just an extra list. If you want to keep it in the H's and T's format, there is another sort of way of looking at it. This is your typical H's and T's, but just added with your pregnancy-related causes as well. So whichever one helps you the most. So just to reiterate the things that we do differently, moms have an increased oxygen consumption, and therefore oxygenation is really important for them in order to be able to oxygenate the fetus as well. They recommend that the most experienced person is at the airway because it is a difficult airway. And then, as I mentioned, they recommend to intubate and then one breath every 6 seconds. If the patient's abdomen or if the uterus is above the umbilicus, or if the patient is known to be more than 20 weeks pregnant, then they recommend uterine displacement. They say that wedging the patient, while useful to relieve the pressure on the IVC, it does make chest compressions and CPR quite difficult. So it's better if someone can actually just push the uterus to the left side rather than putting the patient on a wedge. And then, as we mentioned, that's what's best for mom is best for child. Okay, and then with regards to the resuscitative hysterectomy, so as mentioned, this needs to be started within 4 minutes. It's done if the patient is more than 20 weeks pregnant or if the fundus is at or above the umbilicus. It improves maternal outcome, and it should be done immediately if there are fetal injuries or prolonged pre-hospital arrest. So all of these factors, obviously, as I mentioned, makes the procedure quite a challenging one, and in terms of needing a lot of hands. So you really need a lot of people to do a resus like this. So early on, try to get as many hands as possible so that all of these things can be done. And then primarily your attempt or the reason behind you doing a resuscitative hysterectomy is to improve your cardiac output by reducing your uterine blood flow. So all that blood flow will be redirected to the heart. And it also relieves the diaphragmatic pressure on the lungs as well. So your functional residual capacity, in a sense, should be increased. And secondarily, you are obviously trying to save the fetus if the fetus is viable. So just a quick video. I'll show you the video just now, but this is just a diagram showing how it should be done. Some people recommend starting at the xiphisternum and cutting down to your pubic symphysis. In this picture, you can see they start at the umbilicus and do a midline incision down to pubic symphysis, and then you find the bladder, try to empty the bladder if you can, get the lower uterine segment, make also a midline incision or a vertical incision, and then what they say is you put your fingers through the under the uterus and cut above your fingers so that you're not cutting into the uterus, and then deliver the baby. So this video, I hope it plays. It should play. I don't know if it'll play now on here.
2 minutes to get my gear set up. This is Brett. Brett's my sim guy. Okay, so I'm palpating abdomen. I clearly have a lady in cardiac arrest. palpably pregnant, right fundus well above the umbilicus. So I have my indication to do the procedure, and I'm going to start right at the top, up at the xiphoid, and I'm making a pretty big incision just vertically all the way down to the symphysis. I'm not a surgeon, right? Leon's a surgeon, but for me, I got to cut a few times to get through all these layers, especially for this lady. Okay, you can bluntly dissect as you need. Okay, and at this stage, you can have your assistant retract. I've got uterus here, bladder low down, making a smallish incision in my uterus. You get umbilical fluid splash out there. And I'm just putting my fingers in because I don't want to use scalpel the whole way and risk cutting baby. Using my fingers to protect as I'm opening up the uterus. And for me, I got to make a big incision, right? This is not cosmetic. Reaching in for baby's head. Baby is head down. That's nice. Oh my gosh. And sometimes you need some fundal pressure from the top there to help deliver baby. That's you, Brett. Your fundal pressure. The fundus is up the top. Got it, buddy. It's awesome. Right? Next step in baby, you're clamping the cord, 2 clamps, cut between them, right? Don't make the rookie mistake of cutting on either side. You're passing baby off to your neonatologist who's now doing the hard part, right? Tell me you're going to breastfeed. Okay? You're back at baby. You still need to deliver placenta, right? Placenta is the part of this that consumes all the oxygen. And now, if you're a surgeon, you're making the layers nice. I'm not a surgeon, so I'm packing the abdomen with sterile towels. We use this, we have this. You're closing, and if I have a stapler, which I do not, I am stapling the skin shut. Comme ça. Then you're going back to mom and baby.
I think that deserves some applause.
Okay, so yeah, that video just shows she cut from the substernum down to this pubic symphysis. And as she explained, now picture this happening while CPR is happening. Obviously in this doll they weren't doing CPR, but it's quite a hectic procedure. Yeah, so I think these videos are quite useful just to recap it. This next video is, I'm not going to play it, but I'll send the link on the group. It's a really, really nice sim on the whole maternal resus thing. They don't do CPR during the video, but everything else is really, yeah, it's really useful for, yeah, I'm not going to play that video because it's quite a long one, but yeah. So I'll send the link on the group. Basically, you're going to cut by the pubic symphysis up to the umbilicus or above that, along the midline into the peritoneal cavity. You're going to retract the abdominal wall laterally, reflect the bladder inferiorly and empty. You can either do that by aspiration or by putting in a catheter. You're going to make a small incision into the inferior presenting part until amniotic fluid is seen, and then insert fingers into the uterus and lift it away from the fetus, and then use your scissors to cut up to the fundus. You're going to then deliver the fetus. You might need to disengage the presenting part. You're going to clamp the cord, give the neonate to someone to resus if the baby is viable, and then deliver the placenta, swab the cavity, and then for us as ED staff, we are just going to pack the uterus and close it. You can use cling wrap or whatever is available to try and keep the uterus closed. Generally, it should be quite a bloodless procedure if the patient is in cardiac arrest, but once there is ROSC, there might be some blood flow. And in that case, you should try to tie off any bleeders that may have been created during the incisions. But for the most part, we pack and close, and then the patient should go to theatre if there's ROSC. Again, you're going to continue the resus throughout, and then, as mentioned, you're just going to watch for bleeding with return of circulation. So things to remember is the biggest thing I think with a procedure like this is the difficult step is the decision to start. And I sort of relate it to doing a crike. It's that decision that you have to make, should I, shouldn't I? And that takes up most of the time. And sometimes we're just not sure. So I think by knowing the indications well, it avoids a bit of the hesitation. And just remember that it's obviously a time-sensitive thing. So yeah, I think if we remember that, just that decision to start is sometimes the biggest hurdle to get over. Survival drops beyond 4 minutes, and if it takes longer than 5 minutes, so that's why they recommend that time. But again, if it's 6 minutes or 7 minutes, I think we're still going to be doing it. Continue CPR throughout, as well as ventilation, obviously. So things that influence the fetus's survival is the quality of your CPR, the maturity of the fetus, the time to delivery, if there's availability of an neonatal ICU, and then the pre-arrest maternal state. Of these factors, there's only really two that we have a say in, and that's your quality of your CPR and your time to delivery. The rest we don't really have much say in that moment. So we need to just focus on those things that we can change. And then important to remember that this is a notifiable condition. There's a lot of paperwork that surrounds maternal deaths. We'll go through a little bit of it, but it does need to be reported. Some things need to be done immediately, and the rest can be done the next day during working hours. So firstly, you can notify it on the same app that we use to notify malaria or any other notifiable medical condition. That's one of the forms that we'll need to fill in. And then the maternal death notification form, this is the other form that needs to be filled in. It's quite a detailed form, and it explains nicely how to fill it in. So if you just read through this form step by step, it really gives you a good indication of what needs to be done, who needs to be told, when they need to be told, and all of those sort of things. At the bottom of this form is a nice sort of checklist that gives you an idea of what needs to be done when. So if we just follow this, we should have everything done. Most important thing is if you're sort of on a night shift and this happens with no one else around, you do need to notify matron, notify the consultant, and then I think at least this form needs to be filled in as soon as possible, and then also arranging counseling for the family and obviously alerting the next of kin about the death. The rest of the forms can be done sort of during the day, but just remember that they do need to be completed. So make sure that your clinical notes are written nicely and that it's clear and that everyone that needs to be notified has been notified. This is from your protocol, and I thought it was a really, really nice flowchart describing everything that needs to be done. So your maternal death notification form, that's the one I just showed you now. That's the one that needs to be filled in sort of first. And then depending on the cause of the death, so if it's an unnatural death, like a car accident or something like that, you're going to be filling in your D28 form. It's the same form that we fill in for any non-natural death. If it's a natural death and the cause is clear, you can fill in your normal BI form that we fill in for all other patients as well. If it's a natural death, but the cause is a bit unclear and you'd like to do a post-mortem, then you'll have to fill in a post-mortem request form. This requires consent from the family, so you'll need to speak to them and just discuss with them that we would like to do a post-mortem and explain to them the reasons. And then the notifiable medical conditions form, that's the one that you can do on the app, the same one that we use for malaria and any other notifiable diseases. And then your severe adverse event notification form, that, if I understand correctly, can be done sort of the next working day, but that is also an important form that needs to be filled in, and all relevant parties need to be included in that form. And then lastly, remember that the success of your resus is not determined by whether the patient survives or not, but how well the resuscitation techniques were executed, including the teamwork. So it's not to say that we don't get upset if the patient doesn't survive, but just remember that a resus is not, it can still be done really, really well, and the patient might still not make it. So just keep that in mind. It's not always our efforts can be the best, but sometimes it just doesn't turn out that the patient survives. And then lastly, remember to debrief. It's a very high emotional event, so just get everyone involved together for a couple of minutes, chat about what happened. It's very important, even if you take time after the shift to discuss what happened. I think it's an important thing to remember. And yes, I think that's it. Cool. Hope you guys enjoyed it, and thanks for watching. Have a good evening, everyone.